Hello and welcome, ladies and gentlemen, to this event from CGD on the economic impacts of antimicrobial resistance. My name is Anthony MacDonald. I am a fellow at CGD, where I lead a lot of our work on antimicrobial resistance. Previously, I was head of economic research for the UK's Independent Review on Antimicrobial Resistance, or the O'Neill Review, and my work there included leading the review's work on the economic burden of antimicrobial resistance. So partly because of that, Dame Sally Davis asked me to lead a follow-up study looking at the impact of AMR on the economy using better data. Though, as you'll see, I did not lead this work alone, but it was a very able team assembled around me. This was the most fascinating project of my career thus far, and we tried to tackle the project in a much broader way than before. We first of all had data from the Institute of Health Metrics and Evaluation and their GRAMS project. So we had much better country level numbers on the health side of antimicrobial resistance, which allowed us to do a much more detailed study than could previously been done. There were several work streams on this, which we'll talk more about, but one was to estimate the cost of antimicrobial resistance on healthcare facilities. A second was to look at how other parts of the economy, such as tourism, domestic hospitality, and the labor market, would be impacted by a change in antimicrobial resistance. And we used a range of modeling techniques, as well as expert elicitation and wide-ranging literature reviews to create this information that come out in our paper, which was launched in September, which summarizes all the results. And then we had 3 papers out today, one on the impact of antimicrobial resistance on healthcare costs, in inpatient healthcare costs, a second looking at the macroeconomic impact of antimicrobial resistance in more detail, and then a third one that looks at the cost of different interventions to stop antimicrobial resistance. Throughout this talk, we'll be trying to take as many questions and answers from the audience as possible. So you will have seen there's a link to Slido below your video on this screen. Please do click on it. If you've got a question, write it in. If you particularly like a question somebody else has, please upvote it, because we'd love to hear from you and to get as many thoughts and questions as possible. Today we have 3 excellent panelists. Firstly, let me introduce Tim Lawrence. I'm lucky enough to have known Tim for a long time, going back to when we both worked at Wellcome, where we spent 6 months working full-time on a project to look at how to improve the links between health research and economics. Today, Tim is a UK-based health economist and data scientist, and for the last 2.5 years, he has run Perma Analytics, his consulting company. Through Perma Analytics, he has helped organize helped to develop their health economics and data science capacity. He has led innovative analytical projects at the intersection of health and economics and data science. As well as working at the Wellcome Trust, Tim has previously worked at the UK Treasury, and he holds a part-time job today in the UK Civil Service. Tim led 2 of the project work streams, one calculating the cost of AMR in inpatient hospital care, and a second estimating the cost of rolling out interventions to stop resistance. As part of this work, he undertook detailed literature reviews, rigorous modeling to extrapolate costs of health treatment in different locations where the data didn't exist. And I'm delighted that he's here today to discuss his work. Secondly, we have Professor Amanda Countryman. Amanda is a professor in the Department of Agricultural Resource Economics at Colorado State University. She teaches courses in applied economics, and her research program centers on investigating the economy-wide effects of changes in the international trade, policy, production, and other shocks in global market. She employs computer general equilibrium models, or CGE modeling techniques, to investigate issues relating to agriculture, the economic burden of human and animal health events, trade policy, as well as trade in the environment. And Amanda led the macroeconomic modeling for this project. And I've very much enjoyed collaborating with her over the last 18 months. Her knowledge of CGE models is profound, and her problem-solving attitudes make her a joy to work with. So I'm very glad she can be here today to discuss that work. And thirdly, unfortunately, due to unforeseen circumstances, Professor Dame Sally Davis will not be able to attend today. Sally is the brainchild behind and driving force behind the eco-AMR work, driving both support and funding for the idea. However, she has sent the head of her office and head of international AMR policy for the UK Department of Health in her stead. So we have a very able replacement, and I'm very grateful to Tom for stepping in at such short notice. As mentioned, there will be Q&As, but we'll start with a few questions from me. Tom, what do you see as the economics? So what do you see as the value in economic numbers to tackle antimicrobial resistance? And why did you and the Department of Health commission this research?
Thanks, Anthony. Well, firstly, Sally's asked me to pass on her apologies for not being able to make it today, and has asked me to say a few words. And she did also want me to pass on her congratulations to the CGD team for such an important study. So firstly, the question of why did DHSE commission this research? Well, AMR is a macroeconomic issue, a whole of society risk impacting kind of health, food, environment, and economic security. And as you've shown in the study, labour, hospitality, and tourism are all implicated. So thanks to the data from IHME on burden, as you pointed out, Anthony, earlier, it's now possible to model the economic impact in a way that was just not possible before. And it's probably worth reminding ourselves of those latest figures from the Institute for Health Metrics and Evaluation published last year, which forecast about 39 million deaths between now and 2050 linked to AMR, as well as 169 associated deaths, a huge health burden. And so it's really important to be able to also give an indication of the associated economic burden as well, which you have done. We know that AMR solutions need to have the support of financial institutions, including financial ministries, the World Bank and development banks, investors and insurers. So it's vital to speak their language on using economic data so that they can understand the scale of the problem and prioritize it accordingly in a way that suggests action and more importantly, understand that it can be mitigated and that solutions are available. So thank you for making plain kind of the return on investment opportunities in your study. I think that's really important. The UK envisioned this research as a key part of the roadmap to last year's high-level meeting, helping to show countries of all income levels what was at stake. And as a result, we've helped to secure a consensus-based and ambitious, actionable political declaration. I encourage you to take a look at it. It's a short document, including some strong commitments on unlocking financing for low-income countries, especially. And this research will help the world continue to be able to push for long-term approach that put sustainable finance at the heart of discussions. It was important for your study on human health to be in partnership with RAND's study on animal health, which shows the wide-ranging nature of the problem and how vital collaboration is to address it. We want to avoid this becoming a kind of human-centric topic, and so that collaboration is really important. Dame Sally actually used some of your eco-AMR numbers extensively last week in Davos, helping to make the case to new stakeholders who are unfamiliar with AMR. And I think that's a really good example of how we hope to use these figures going forward and this important study. Thanks, Anthony. I'll hand back to you so we can get stuck into the figures themselves.
Thank you very much for that, Tom. And I would say I was very happy to watch Sally speak in Davos from afar and to hear her quote our research. Tim, what do you think what did you find that the impact of AMR would be on healthcare systems and on treating people?
Great. So when Ante and I first started working on this study, we knew there were studies on global health burden of AMR. For instance, it's been mentioned already, IHME's GRAM study. But the impact of AMR on healthcare expenditure globally was not well understood. We set about estimating the direct inpatient healthcare expenditure due to AMR in 204 different countries. We use IHME's estimates of disease burden, along with an additional review of epidemiological studies led by Olympia Lamberti to estimate the number of inpatient admissions with AMR. And the focus on inpatients as opposed to other parts of the healthcare system was because that's where a lot of the costs lie. So we conducted a novel review of AMR-related healthcare costs to estimate the cost per admission, disaggregated by 11 different infectious syndromes. And all of this was combined in a cost of illness type methodological framework, which people are probably quite familiar with from other studies. Our cost review yielded estimates of healthcare costs for 70 different countries. So, but sometimes we found there was kind of no data for the cost of an admission for a given infectious syndrome in a given country. So we use several different statistical model specifications to estimate these missing costs. Where obviously some people can rightly be want to kind of question what's driving these and why we think these models are good, we assess the performance of these statistical models using 5 tests of suitability of the emerging estimates. And these tests, which you can read more about in the study, we use these to try and ensure the estimates are as accurate and as credible as possible. So this allows us to estimate the cost per admission with a resistant infection and how much this varies among different infectious syndromes with different types of illness. We also estimate the excess cost caused by the resistant by comparing the cost of a resistant admission compared to the cost of someone with a comparable susceptible infection. So what do we find? Overall, we estimate there are around 25 million hospital admissions with an AMR infection globally each year. And this is subject to uncertainty that's quantified in the paper. This means we estimate around 1.3% of global admissions involved an AMR infection, so really quite a lot. Overall, our estimate of the global excess direct inpatient healthcare expenditure due to AMR is around 66 billion. This estimate is lower than the most comparable estimates. People probably saw the World Health Organization study on this published last May. So we come in a bit lower than those estimates. Our estimates are broadly in line with some other previous sub-global estimates, but notably higher than some key national studies, despite our intention to make conservative model assumptions. This divergence is largely explained by these previous cost studies using lower estimates of admission volumes for the US or Europe, which are kind of important geographies for thinking about the overall global cost. We find the expenditure on AMR admissions is a particular concern for lower and middle income countries, which we find spend higher proportions of already tight healthcare budgets treating resistant infections. We use our kind of estimates of the current costs along with IHME's prospective scenarios of AMR burden published last year to estimate how the cost of AMR is likely to change in the future. This is obviously subject to considerable uncertainty, but we find that excess expenditure due to AMR is likely to increase. In our reference scenario, it increases from around 66 billion to around 160 billion by 2050. In more pessimistic scenarios, there is a possibility this increase could be even greater. And in our most optimistic scenarios, excess expenditure is likely to remain stable over time. Stable might sound good, but what that means is that without intervention, we see no plausible route for these costs to go away. And the likelihood is that these costs will increase considerably. We look at some interventions in this modelling and find that antibiotic development, improvements in access to healthcare, improved coverage of water, sanitation, hygiene, and vaccines all have the potential to reduce these costs meaningfully. And for individual interventions, you can read more about it in the paper. I'll pass back to Anthony.
Great. Thank you very much for that, Tim. So I can see that we have lots of people watching online, which is great, but we have not got many questions yet. So please do send them in. As well as Tim's work on healthcare costs, we also did a study, as I mentioned earlier, to look at how much different parts of the economy might change because of AMR through a mixture of modeling, literature reviews, and expert elicitation. And essentially, we calculated the cost of labor, a combination of people dying or being ill and leaving the labor force, with the possibility that some people might have to leave the labor force if resistance gets very high because they are scared of, or they have health issues or are worried about getting ill. We also looked at the impact of tourism, and the general sense was that there would be a much larger impact on tourism if one country saw a rise in AMR than if every country saw a rise in AMR, because people might want to go on holidays anyway, but they're particularly but they'll avoid a high risk country if there are low risk countries that they can go to. And similarly, we looked at the impact of domestic hospitality, as we called it, which is things like going to the cinema, out to a restaurant. The changes of these are all, we think, going to be quite small relative to something like COVID, but you could foresee a world where there's a 1-2% reduction in tourism because of a rise in AMR. And when you take into account that tourism is $9 trillion a year, roughly, that becomes quite a large amount of money. Anyway, along with those estimates and Tim's work, we then had to design an economic model to estimate the overall impact on the global economy. And I say we, but this work was all very much led by Amanda Countryman. And so I guess, Amanda, my question for you is, what is the economic impact of antimicrobial resistance going to look like?
Thanks, Anthony. So first and foremost, the macroeconomic impacts of AMR depend on many factors, and most importantly, depend on how resistance rates evolve over time and how people and policymakers respond to those changes. So our estimates overall show that if resistance is not curtailed and AMR accelerates, global GDP could decline by $1.7 trillion by 2050. And as Anthony previously mentioned, to reiterate, this is driven by the negative impacts throughout the economy, given changes in population, increased healthcare costs that Tim just nicely explained, the labor effects, both direct labor effects and indirect labor effects, where we have the direct implications of people getting sick and the impacts on labor in that regard, as well as people changing their behavior in terms of how they work, potentially, if AMR does accelerate. Again, we also have those potential decreased demand for hospitality and leisure activities, and again, potential for decreased tourism. However, we also investigated the potential for 4 AMR improvement scenarios, where we considered the potential for improved treatment of bacterial infections, innovation and rollouts of gram-negative drugs, better access to vaccines, clean water, and sanitation. And we found that giving a 4-part intervention strategy, or the most optimistic scenario that we considered, global GDP could increase by $990 billion. And so the potential implications are relatively large upside potential if we can have combined intervention strategies, but a lot of downside risk if AMR is not tackled and curtailed. I also think it's really important to think about how AMR affects countries differently. And so in our study, we accounted for individual country effects of AMR, and we also investigated country groups. And so for the optimistic scenario, what we found that is important to consider is that there are larger potential gains for lower income countries, again, in the optimistic scenario, and that's primarily driven by labor, tourism, and hospitality effects. But on the negative side, for the pessimistic scenario, again, very important to think in context that upper middle and high income countries potentially have the most to lose in terms of GDP. That's driven again by potential decreases in demand for hospitality and leisure, tourism, as well as those labor effects. So overall, if AMR gets worse, the macroeconomic cost could be $1.7 trillion globally. But on the other hand, if AMR improves, the benefit could be almost $1 trillion. So again, lots of potential upside, but also the downside risk is extremely large. So again, thank you, Anthony, for the opportunity to share our results with you, and I look forward to our continued discussion.
Great. Thank you very much for that, Amanda. And it's good to see questions starting to come in, so very much appreciate that. I'm going to ask one more round of questions each, and then we will come to the audience. Tim, the last part of the project was to do work on the economic impact, on the cost of rolling out interventions to stop antimicrobial resistance. So how difficult of a problem is this to fix?
So as part of this study, IHME, as both me and Amanda have mentioned, modelled several different prospective scenarios of burden of AMR out to 2050, including interventions seeking to mitigate AMR. These intervention scenarios are developing new innovative gram-negative antibiotics, improving access to healthcare and existing antibiotics, improving access to wash for households, wash being water, sanitation, hygiene, improving access to childhood vaccination. So we estimate the cost of these interventions for 204 countries. For some countries we couldn't where there was data missing, but we tried to do it for all the ones we could. We often update other authors' estimates where available, obviously because there's a huge amount of great research already on these topics. We do some original costing work where required. For instance, we develop a new novel Cobb-Douglas production function for those economists on the call to cost our better access scenario. These intervention costs are compared to intervention benefits in other parts of the EcoAMR study, so mainly the paper Anthony led that came out last September. Country level estimates for these interventions are also available in the report, in the appendices of the report, so do have a look. So the highlights of this work for me really are that innovation is really very affordable at a global level. So we estimate the annual expenditure required to develop new gram-negative antibiotics is around £2.2 billion annually. So that obviously sounds like a lot of money for any individual on the call, but this represents only 0.002% of global GDP, so a tiny fraction of the total economy. 0.02% of global healthcare expenditure, which again isn't very much considering antibiotics underpin so much of modern medicine. It's 0.1% of total global research and development spending, so again affordable by that metric. For people who don't spend their whole time thinking about statistics, trying to give you a more tangible idea of why that's so affordable, Disney invested more than double this cost on its theme parks last year. So, you know, the global economy does support other things less essential than this antibiotic development. It's the same as the overall revenue of the top 3 earning football clubs for football fans on the call. And it's less than the cost of buying a cup of coffee for everyone in the G7 collection of kind of wealthy nations. We also costed access for the first time, and these estimates are very uncertain. So we'd love to engage with other research and policy people to develop them further and get to the questions that people really need to kind of drive some of these debates forward. The price tag here globally is £59 billion, which again sounds like a lot of money, but this is only 0.5% of global healthcare expenditure. Costs on vaccination and wash are also available in the report, but I'll hand back to Anthony now.
Thank you. I love the statistic that it is half as much as Disney spend on theme parks every year. These are not difficult costs in other areas. And I think we found it's 28-to-1 return on investment for when you look at the costs and the benefits from these. So Tom, you, as you mentioned, brought in this work to try and stimulate global action. We've already had the announcement of an independent panel and the global declaration. What do you hope, and what is realistic to hope for going next in terms of achieving consensus around AMR?
Thanks, Anthony. Well, I think the scale of the kind of figures that have just been indicated to us gives a kind of sense of how important tackling this issue is. And the high-level meeting last year gave the world a kind of clear task to save lives from AMR. We've got a target now agreed by member states of reducing AMR-related deaths by 10%. And we kind of hope that target will help to mobilize resources from countries as well as multilateral financing sources. We can also use the economic figures and analysis to help us keep accountable and remind us of how and where we can make inroads. And you've already highlighted the kind of strong return on investment on AMR solutions. So we know that not only are there solutions available for this problem, but that they are cost effective. And I find, I mean, sustainable finance was a priority for member states at the high-level meeting. So a kind of key next step will be to share these figures with those making investment decisions from ministries of finance, World Bank, country offices, health insurers. And this is going to be vital if we can leverage existing financing and make the most of what is already out there. And we think there is significant resources untapped out there. One of the actions in the high-level meeting political declaration was to map out the financing that is available for AMR, which will be led by the quadripartite Joint Secretariat and the World Bank with support from WEF. We think that's a really useful step forward, so we have transparency over where resources are available. We need to broaden the number of donors out there to the multi-partner trust fund as a matter of urgency. That is a fund that directly resources national action plans in low and middle income countries. We need to leverage financing from pandemic and climate financing and work far more closely and link together private, public and philanthropic sectors. We need to go beyond aid, clearly, and one of the most promising examples at the moment are the 80 investors who've come together to recognise the systematic financial threat posed by AMR, calling on global leaders to act and establishing guardrails for these investment portfolios. As much as we have great data now and we have great evidence, we need more. It's one of our top priorities for the new independent science panel on AMR, which was committed to last year as part of a high-level meeting. We want this to be established rapidly and well. This is going to help countries make the case for financing national action plans and provide good recommendations, which will be helpful to all. It's our hope that the panel will be based at the UN Environmental Programme HQ in Nairobi, so it can consider not just the human sector, but animal and environmental aspects as well, and hope that being rooted in Nairobi will where the burden of AMR is greatest will provide really good impetus. The UK and the EU have already committed funding to this panel, of course, as well, to ensure that the global south can fully participate. It's worth highlighting, in addition to high-level meeting work, and this has been touched on, we really need to support innovation to address the gap in the antibiotic pipeline. So we need countries to pilot pull incentive models that work for the healthcare systems. That's going to be a real priority going forward. And we think these figures obviously can support that case. The subscription model, the UK subscription model is continued to be rolled out, and there are a number of pilots ongoing that countries are joining in, with Japan and Italy having announced a fair share contribution as well, which is great news. And so there is reason to be hopeful, but we do need other countries to join in on that as well. We don't just need innovation for antibiotics, we need it for diagnostics and vaccines as well, of course, and for animal health, not just humans. So there's a lot to be done, but I'll hand back now, Anthony.
Thank you very much for that, Tom. So this is the last question from me until we go to the audience. So do get your questions in. Amanda, I find it very hard to conceive of what $1 billion really means, and I work in this area. I googled it, and it's 2.5 kilometers tall if you stack $100 bills and you get $1 billion. So obviously it's not a figure that most of us are used to, but what does $1 billion, or I guess what do these figures, which are almost $1 trillion, mean for normal people?
Thanks, Anthony. So it's a great question, and I think really important to put this into context. So I think about the potential for AMR to affect people's lives in a variety of ways, beyond just these dollar figures that are at the global level. And I also just want to say how important it is to keep in mind that this is a truly critical problem that is already affecting people's lives already. And so hugely concerning if this were to get worse and we don't have coordinated action against mitigating this really negative health event or health crisis, so to say. So for me, I think we can think about or consider two general pathways by which AMR affects people in their day-to-day lives. We've already talked about most of these things, but we can put it into further context. So first, I think about, in general, two pathways. The direct health-related consequences of AMR, which I think are, for me, the first immediate things that we think about. So if people become sick or die, that has a dramatic negative effect on people's lives, and also has negative implications for the workforce. If people are not able to work as much as they were before, or if they are no longer able to work because of deaths, and primarily healthcare becomes much more expensive. So when we think about household incomes and the share of income spent on healthcare, as Tim already talked with us, healthcare will be just frankly become more expensive. And second, it's important to think about the pathway of these behavioral impacts. So again, our work explores these behavioral impacts as people may become more risk averse if resistance rises. So if we think about it, if resistance rises and people actually start to change their behavior because of fears related to AMR, that has a direct impact on people's day-to-day lives. People, again, may switch jobs to lower contact positions to potentially avoid getting sick, as well as avoiding high contact activities like sporting events or concerts, things of that nature. And as you already mentioned, potentially avoid or change and alter tourism behavior. So again, when we think about the potential health-related and behavioral changes that could come from AMR, these all have negative impacts on people, potentially in our day-to-day lives, even if we don't become sick from an infection. And then we can think about those negative impacts extending to the country level and then also the global level overall. So again, the impacts are dramatic on people from a day-to-day perspective, and we can think of that in terms of not only these direct health-related consequences of AMR, but also the potential behavioral impacts that may start to affect our decision-making in terms of how risk-averse we are, considering the things that we do on a day-to-day basis. Thanks, Anthony.
Great. Thank you very much for that, Amanda. So we have some questions from the audience. Firstly, Duncan asks, what would be the impact of this research at a country level? And could we give any examples? We have, Duncan, put out papers today that have in the appendix country level breakdown, so you can find the numbers there. And then similarly, Michael asks, why do IHME CGD estimates differ from official estimates of MDR in the UK? Now that our health numbers all come from IHME who are not on the call, but somebody might want to talk about that too. So Tim or Amanda, I guess, do either of you want to talk about country level impacts?
Do you want to start, Amanda?
Sure, I can start. So first off, in the study, we investigated 122 individual countries, in addition to 4 aggregate regions that are a combined grouping of relatively small countries in the world. And so in the paper we've presented the country level results in 2 different ways. So we have country level maps that are within the main body of the report, where we have a color coding of the severity of the GDP effects and also the economic welfare impacts, which I think it's helpful if we can look at a map of the world and we can just see visually how the potential impacts across scenarios may differ. And then furthermore, at the end of the report in the appendix, we also do provide country level estimates. And importantly, one thing I'm incredibly excited about, and this is truly a result of the really important support for this project. So then again, thank you to the UK for the tremendous support of this, is that we have a virtual tool that is coming very, very soon, where users, stakeholders, anyone will have the opportunity to put in a specific country and a set of expectations about the different varying levels of potential AMR to see what those country level impacts are. So it can be a challenge when trying to take a topic that, as Anthony's already mentioned, affects people on an individual level. We then try to understand that at the country level and then communicate from a global perspective, because it truly is a global challenge. What are the overall global effects, which are what we have focused more on in our discussion of the numbers, but both in each of the reports and very importantly in the online interface, you'll be able to see those country-specific numbers to get much more detail about any of the 122 individual countries that you're particularly interested in learning more about or digging deeper into the results for. Tim, would you like to add a bit more on the healthcare cost side, where individuals might be able to find more information?
Absolutely, yeah. So in terms of the healthcare costs, the report that came up today, and hopefully can be linked in the, it is linked in the chat, I can see, will allow people to go to the appendices, where we just have a really long table, because where people will be interested in their own national context, we just wanted to make sure they could find their own national information as easily as possible. So we give our estimates of admission volumes. I should say that wasn't kind of the primary focus of this research, so we tried our best to do those estimates, but if people find they do diverge from other existing estimates, then there'll be a lot of reasons for that. We have a long table trying to compare to all of the different studies we know about, the main studies of healthcare costs, healthcare volumes with AMR at a national level, to try and explain why some of our results might differ from other studies. And I should say a lot of this modeling yields estimates, which do have quite a lot of uncertainty. People reading the national estimates will see that we have these quite wide bands on uncertainty. And that's just because some of this evidence is, though quite strong, also quite uncertain. So we just try to quantify that in the work. So yeah, and then just as well to give a plug to the tool, I've seen early versions of it, really looking forward to it being published, because I think that will be another place where people can go to get their questions answered about what this means at the national level.
Great. Tom, anything else that you want to add on the country level estimates?
Yeah, I mean, very quickly, there are clearly real practical applications for the country level estimates in terms of providing countries with figures to support business cases for investing in AMR, and not just in countries for business cases for ministries of finance, which could be a target of a state, but also for discussions with country offices with the World Bank, enabling low and middle income countries to go to the World Bank with kind of an estimate of the cost that AMR is having currently in their country and forecast, which will help support business cases there as well. And I think we know from a number of evaluations we've conducted overseas, it's really important that, as Tim mentioned, to be transparent around, the challenges around the data, that these are estimates, but these are clearly the latest and best that we have available to us, and so will be incredibly useful in that context. Thanks.
Great, thank you very much. Another question we have is, what do you think about some type of advanced market commitment for AMR point of care diagnostics for UTIs and for other respiratory infections to pull innovation? Does anyone have any thoughts on AMCs that I want to jump in? It's a little beyond the scope of the talk, so
yeah, I'm happy to have a first go. So I think a lot of the time, though we haven't covered diagnostics as a specific intervention, what we found kind of just by reading lots of this cost evidence is getting people the right treatment and right antibiotics is really important for improving their health, but could also have an impact on reducing healthcare by, if you get people healthier quicker, they're in hospital for less time, and that's a good thing too. In terms of specifically an advanced market commitment, though I'm an economist, it's not an area I've studied that well, except a bit of reading. I think to the extent that it could give more incentive to develop low-cost diagnostics that can be used around the world, it could be a really useful thing for trying to help incentivize the development of new antibiotics, trying to make them affordable around the world, to make sure that we can better understand what's going on with what's making people sick, use antibiotics responsibly, and try and ensure people get healthy as soon as possible.
Great, thank you very much. So another question that we've had come in is, how does this work compared to other studies such as the WHO's one on health and AMR review and World Bank studies on the economic burden?
I'm happy to go on the healthcare side. So I think I mentioned in my opening remarks, so WHO did a great piece last May. I think it was published. So where our work differs from theirs, and people can go into, there's a whole paragraph on this in our report where lots of people will be interested, uses slightly different data, slightly different methods, slightly different evidence. They don't publish their kind of national estimates. I'm not 100% sure if they have national estimates. All they publish in their kind of modeling annex is the regional, so WHO regional level. So not quite as specific for individual countries, which is where a lot of these decisions might take place, where our study does that. Obviously, the national estimates are more uncertain than the, global picture potentially, where you're getting down into kind of finer grained geographies. But we do make those available because we're aware that lots of people will want to use them, even though they're uncertain. In terms of the quantification, our results come out a little bit lower. If people are thinking about the kind of headline 412 billion pounds a year figure, that refers to the total cost of an admission with AMR, I think, where we tend to talk more about the excess cost. So our most comparable figure to theirs from the paper is around about 190 billion pounds a year, if you're including the total cost of an admission with resistance, and that's the average from 2015 to 2035, which is how they did their headline figure, I think. So we end up being about half the level. That sounds like a big difference, but where there's so much uncertainty in this data and evidence, you can find just trying to measure the costs for a given pathogen resistance pair in a given hospital, that can have quite a wide uncertainty range. So actually, generally, I think our kind of results are fairly supportive of each other's, rather than necessarily saying different things, even if the exact size of them is a bit different. So yeah, pass back on to Amanda maybe on something else.
Thanks, Tim. Yeah, so when we think about it, as Tom very importantly reminded us, that over time we get more information, more data, better information, so that we can more comprehensively understand what the potential implications of AMR are on people in the economy. And so when we think about two pivotal studies on the macroeconomic effects of AMR from a global perspective, we had the O'Neill Review in 2014, and the World Bank published a very nice study in 2017 also. And those studies consider more of those primarily direct impacts of AMR, as I previously discussed. So the population, healthcare related, and then the direct effects on labor. And so our work is the first to our knowledge to investigate more of the behavioral effects or potential behavioral effects of AMR. So we know that there is more to the story of the impacts of AMR beyond those direct health and mortality related, healthcare cost related impacts. And so that's why we do our best to try to understand if we do have these potential behavioral changes with increased risk aversion, for example, the indirect labor implications of people perhaps considering different types of employment or even different types of behavior related to the activities that they pursue on a daily basis, then that provides a more comprehensive understanding. And so I really like what Tim said, is that, you know, the addition of our study contributes to the really important work that's already been done. And the hope is that we can continue to expand our knowledge and understanding of what may happen to further inform how important these intervention strategies are in terms of the strategies at face value and how they can dramatically affect AMR rates over time, but then also translate that into what that may mean for people within individual countries and also society as a whole. So again, rather than focusing on differences in the numbers and the estimates that come from these studies, it's really important to think about what each of these studies are incorporating into the analysis. And again, our work is furthering the investigation of the impacts of of AMR by accounting for additional behavioral changes that we believe are part of the story and how AMR affects people, countries, and the world as a whole.
Great. Thank you very much for that. Just to say, we have, if you have a question you'd like to ask, then please feel free to jump in. The QR code is there on the screen for Slido, which allows you to both ask questions and also to upvote questions that you like, so that you can vote so that a question is more likely to be heard. But the next question we have is, how does this assessment help with WHO costing tool for AMR and national action plans and interventions? Is it similar to the WHO tool and thus able to help countries assess their finances for AMR?
I'm happy to start on that one, maybe from a healthcare cost side. So the WHO choice tool is great, and you could produce estimates of, you know, what's the cost of an AMR admission using the WHO choice tool and things. And I know that tool fed into the WHO's approach to doing their own similar study to this. So what you'd need to use the WHO tool to try and replicate some of this, you'd also need to know length of stay, because I'm pretty sure that the tool focuses more on what's the daily cost of inpatient care in a country, rather than what's the total cost of admission, which is what we focus on. So you'd need to know about length of stay, and you need to know comparatively length of stay differential for resistant versus susceptible infection, maybe, if you're interested in what's the excess cost of AMR. So basically, our study kind of just has an estimate of that inbuilt, where we just looked at what's the total cost of the admission for different countries around the world. So if different countries around the world tend to have different lengths of stay and things like that, or maybe the costs recorded are a little different for AMR than for general inpatient care, our approach will capture that. But yeah, where these costings can be uncertain, definitely encourage researchers working on kind of national costings to look at a range of different sources. And hopefully our results will add something really useful to those kind of national action plan costings. I guess the only other thing is, for national action plan costing, you might be interested in costing the interventions. We do have estimates for a few key interventions that we looked at in this modeling. I should say that there is the potential, though, where we were looking at the global level, to do more detailed work at the national level. So if you have competing estimates where people have done really detailed work in just one country, you should probably prefer their estimates to ours, which are at a more global level. And so we've not been able to incorporate all of the nuances of every different national country. If you don't have a cost for an intervention, though, hopefully the cost in our tool can serve as kind of like a credible baseline, potentially, until more detailed costing work emerges for your kind of national context.
Great, thank you for that, Tim. Tom, anything from your perspective?
Yeah, just very quickly. I think this is a matter of a kind of audience as well. I can imagine the WHO costing tool getting quite a lot of traction with ministries of health, thinking about the best investments that they need to make in the context of infection control, etc. But I think in terms of the macro and strategic case that you're making with a Ministry of Finance, I can see these analyses being really helpful, having a bit of a bigger picture and being able to compare and contrast different countries. I think is really important as well. It helps us global actors to understand where they can place resources which are needed. So I'll hand back to you, Anthony.
Great. Thank you very much for that. This is probably our penultimate question, so there's just time if you want to add one more in. When you have analyzed different interventions, have you considered the interdependencies between interventions and coordination between countries? I mean, I can start on that maybe. We at the moment the scenarios that we examined were all agreed with IHME and the Department of Health, but all chosen ultimately by IHME and led by them, and they looked at rolling out all of the interventions globally at the same time. So there isn't a specific what would happen if Canada did X but nobody else did type intervention. I think that would make a really interesting follow-up study, but it would be a much more computationally challenging project, which is why we did not take that approach thus far. Anything else anyone would like to add on that?
I can add a bit on that.
Great.
So I think this also highlights again the need for continued work. So when we investigate challenging questions or challenging topics like AMR, we always identify the additional work that we still need to continue to pursue. And for the macroeconomic modeling that we've done so far, as Anthony just described, we're assuming that we have the investments to create the innovations and the different types of intervention strategies. And in this study, we focus on the impacts of those interventions. I think there is definitely room to investigate further scenarios. While we've analyzed a lot of different scenarios related to AMR, there is definitely the potential for trying to investigate this interdependency if some were to potentially opt out of not contributing towards this challenge. But we'd highlight again that the other key point of this work is to highlight the fact that AMR does not happen in isolation and that there is interdependency between countries. Regardless of the intervention strategy, the impacts will be felt throughout the world. And so, again, I would just highlight that there is definitely more work to be done to try to understand the varying implications of different types of participation in AMR mitigation strategies.
Great, thank you both for that. Another person asked, what is the breakdown of where investment would go? How much would go to academia versus startups versus large pharmaceutical companies?
I'm happy to have a go at that one. So I think in terms of the costing, I assume this means of the innovation scenario for the discovery of new antibiotics, because I think that's a lot of what would be referenced by this question. In terms of developing new antibiotics, there's obviously lots of different players in this space where often you see in medical research funding that academia tends to do kind of earlier stage preclinical work and different that kind of lots of the lab work. And slowly it's more likely the private sector will get on as something moves through clinical trials. The way we've kind of done that costing, and this was actually something Anthony led, so feel free to add anything, Anthony, here. He's focused on a couple of different estimates of how much it costs to develop a new drug. And what the share goes really depends on incentive structure. So right now, probably pharma companies are potentially less willing to invest in AMR where there's slightly less profit in it, where when antibiotic is on patent, you're less likely to see it used in large volumes because of the need for stewardship of the finite resource of kind of antibiotic effectiveness. So you'd likely see kind of a role for all of these groups. If you changed it to make this more profitable, you'd see more private sector. But if, as it is now, it's kind of less of a high return on investment for pharmaceutical industries, you'd probably see more of this research being done in academia and probably funded by governments, which is a lot of what we've seen to date. But I don't know, Antti, if you have anything you want to add to that.
Just briefly, I think I think what you said is absolutely correct, and ultimately, at the moment, we mostly fund other drugs by when they reach the market, but that doesn't mean the money doesn't flow to different people who lead on different stages. So most pull funding will go to pharmaceutical companies. Most push funding will go a mix between academia and tends to be smaller pharmaceutical companies, though not always. But I think we were presuming that it wouldn't be very prescriptive. So we quickly have time for one last question, though I'd ask answers to be brief. A recent World Health Organization report found that TB vaccines could have a tremendous impact on global AMR by sparing between 1.2 and 1.9 billion antibiotic doses annually. How could economic modeling help demonstrate the need for investment in TB vaccines?
I'm happy to start on the TB side because it's one of the infectious syndromes we explicitly model in the healthcare chapter. So I think we do publish the TB figures separately from some of the other figures because we're aware that as a disease area might have a slightly different audience from some of the types of AMR. So we do estimate the cost of resistant TB. We compare that to another study of the overall cost of TB. And I think we find our work implies that the cost of resistant TB as opposed to other TB is around about 36% of the total, I think. And I'm sorry if I've got that number wrong, but I'm just trying to recall what it is in the paper. So basically, we find that resistant TB could be quite a big part of the total TB cost. That is obviously subject to uncertainty. In terms of the overall cost, it's less than 10% of the global cost. So for context, I handed my shocks over to Amanda, who then ran them through the macroeconomic model. So TB is probably not the main driver in the macro model, but I might be wrong actually, because it does cause some death and disability for people of working age. So I don't think we have those numbers off the top of our head. But yeah, I think our results are kind of really important. We have TB scenarios in some parts of the reports, maybe not in all of the parts. But do just let us know if you have any questions as follow-up.
Great, thank you very much for that, Tim. We are unfortunately almost out of time. I wondered if any of the panelists had a quick kind of 20 or 30-second comment about this event or the work that you'd like to share before we send people on their way. Tom, you're nodding.
Yes, just to say, I mean, again, huge thanks for this really important piece of work. I think from DHSC's perspective, we're keen to maximise the value of this by making sure it's shared appropriately. And so I'd encourage the audience to share this and discuss with their stakeholders and colleagues. Really excited about Amanda's reference to the development of a toolkit, which will help countries engage and stakeholders engage more with this data and unpack it. I think that'll be the next kind of milestone in kind of thinking through the impacts of AMR on economics. So looking forward to seeing that and supporting that as well.
Great, thank you very much, Tom. Amanda, any final thoughts?
Sure. Well, I would also just like to echo a big thank you for both the support of what I think is incredibly important, valuable, and I hope impactful work to shed light on just how important this issue is, both at the country level and at a global scale. And I also hope that again, with building on the great work that has already been done, just to really highlight a further need and call to action for how important this issue really is from a global perspective. So I'm tremendously appreciative to have been involved in such an important and impactful project, and just really look forward to what I hope will be a continuation and expanding on the effort to understand the implications of this global challenge. So thanks again.
Great. And finally, Tim.
So I think we're almost out of time. So thank you just very much for the opportunity to be involved in this work. And thank you to everyone for listening today. Really happy to have follow-up discussions if people are kind of interested in this work or doing further research in this area. Just really keen to engage in this area moving forward.
Great. Well, that just leaves me to say, first of all, thank you to Tim, Tom, and Amanda for coming today. And indeed, thank you to the many other researchers who worked on this project. And thank you to everyone for coming along and listening. If you are interested in more information, you can check out CGD's website, where there are 3 working papers on this that went out today, and sign up for CGD's health mailing list, where we will keep you informed of all big updates. And as Amanda and Tom mentioned, there will be a tool coming out in the future and another paper on kind of how different parts of the economy might be affected by changes in AMR. But that's all from us for today. Thank you very much and have a wonderful morning or afternoon.